Good morning, Chris Hull, Wake Forest University School of Medicine, Infectious Disease, here with a viral update. You thought I was going to say COVID update, didn't you? But we will talk about COVID this morning. It's kind of the hot new topic. Yeah, it's January, even though it may not feel like it. Just a minute ago, we were talking about thunder yesterday morning, temperatures in the 60s, but it is cold and flu season, respiratory virus season. And as we talked about in December, before we went away for our Christmas break, our cold and flu season started early this year. And throughout the fall, we were having troubles with flu and with RSV in particular as the respiratory viruses. And our children's hospitals were particularly busy, as our pediatricians were. And influenza in adults was a big deal. If you look at the curves, our flu peaked probably last early November and has been coming down slowly since then. So what it looks like is that we had an early flu season, but not maybe necessarily a prolonged flu season. The peak of flu was a little bit higher than what we would normally see in February, which is where we usually peak. So a little bit of an oddball year. COVID's thrown curves with us with respiratory viruses for the last 3 years, and this year was no exception. Will flu come back? It wouldn't surprise me if we don't see a smaller wave come back this February and March. But I think that the flu being our predominant virus is going to be a fall thing, our last fall, and not so much our January, February respiratory virus season. So what's going on now? We have a lot of viruses circulating right now. Flu's coming down. RSV is coming down and has been for a couple months now. The regular old cold virus, which we call rhinovirus, rhino meaning nose, and because that's where the symptoms mostly are, is circulating, particularly amongst kids and now in our schools. But the big story right now is COVID. So what's going on with COVID? Well, as we predicted, as flu came down, COVID would show a resurgence. And we were saying that we'd probably start to see that over Christmas break. And sure enough, that's what was happening. While the numbers of absolute cases, if you're one of these people who check the dashboards regularly, you'll see maybe a little bit depressed. That's sort of a reporting artifact, actually, because not as many people go to the doctor over the holidays to get tested, which is our main way of getting numbers. Over the last year, with the availability of home testing, most people now test at home for COVID, which is a perfectly fine thing to do, rather than go out and try to find a test in an urgent care or at their doctor. But we have a lot of indications that our COVID numbers are coming up, and they're coming up pretty quickly, actually. First thing is our test positivity rate. That's the percent of our tests that we do that are positive, is knocking on the door of 18%. During the height of the Omicron peak last January, a year ago, that was in the high 20s. So we're getting close to the 20 mark in our test positivity. The other thing is our wastewater numbers are going up. So as you probably know, over the last year and a half, we've been checking for COVID viral particles in our sewage, and those numbers are going up. So more people are pooping COVID, so to speak, because the virus, when it infects our respiratory tract, obviously we swallow it, and then it gets in our feces, and it gets in the sewer. So we can measure it and see how much is in there and follow it that way. Our case numbers are going up. If you here at Atrium Health, Wake Forest Baptist, and they have been now for roughly the last 3 weeks, and the rate that they're going up is going up faster. Our hospitalizations in our health system here in the Triad are also going up for people being admitted with COVID or due to COVID. And so some people who get admitted to the hospital just happen to test positive incidentally. You know, they come in, they broke their leg in an ATV accident, for instance, and they get tested for COVID and it's positive. But we are also seeing more ICU admissions and more people with COVID pneumonia in our hospital. So COVID is coming back, and we are having a beginning of a wave. And exactly how that wave will play out, I'll tell you what I think in a minute. So why is it coming back? Well, the main reason are probably twofold. One is that it's respiratory virus season, and so these viruses take advantage of lower humidity, colder weather. People are indoors more, they're together more, but the virus also survives a bit longer in the air and on surfaces when it's colder and less humidity. The other thing is the holiday season is a time to be jolly, and when you're jolly, you're with other people being jolly together, and that gives the virus a chance to transmit within families and friends and holiday parties and workplaces and so on and so forth. So those are the main two reasons. So even if we would have completely sheltered in place for the holidays, I still think we would be having an increase of cases. But the fact that holidays are a get-together time amplifies that. What's going on with variants? Well, the last time we talked, our main variants here in the triad were BQ1 and BQ1.1, which are sort of grandson and granddaughter of BA5, which is what caused our wave last summer, and great-granddaughter and great-grandson of the original Omicron in January. And in our area here in the triad, that is still true. But what a lot of us are watching right now is a new variant called XBB 1.5. So XBB 1.5. This one's a little bit more distant from BA4 and 5, and actually is a recombinant virus. I'm not trying to bore you with too much science, but what is a recombinant virus is when two viruses, messenger and RNA, get together, pop a bottle of wine and light some candles, and then exchange their information, and you get messenger RNA that's half of one virus and half of the other, and it creates a whole new virus, and that's what XBB 1.5 is, and that means it's different enough that it has more immune evasiveness. So for people who've had COVID before or who've been vaccinated before, or for those who've had both vaccine and COVID before, it's going to be more likely to cause a breakthrough, quote, breakthrough infection. The other thing is that this one has a mutation that makes it attach a little bit better to the receptors in the back of our nose and throat, which is where the virus first attaches it when we inhale it from other people or from particles. And that makes it a bit more infectious. So of all of the variants that we've seen since the beginning of COVID, this one seems to be the most infectious of them all. What does that all mean? Well, this variant, the XBB 1.5 recombinant virus, has been the predominant virus in the mid-Atlantic and New England now for at least 3 weeks. In fact, it started to surface just right after Thanksgiving, but it's really kind of exploded in those areas. And now it's 80% of the viruses that we sequence out of New York and New Jersey. So that is their variant. Down here in the triad, it's only about 10% of what we're seeing. But I think just like what happened in New York and New Jersey over the next 3 weeks, XBB 1.5 will be the story here in the triad also, and will be our predominant variant. And so put all that together is that we're looking to surf a little bit. We're going to have a wave of COVID. What will that mean for our society and for people here is that one is that there'll be more people with colds and flus, which is what we usually see this time of year. And it also means COVID will be the predominant virus around. And the other thing that it means is that particularly for elderly people or people with underlying health problems, we're going to see more of them in the hospital. And that's something we're going to have to look out for. And that's kind of what happens with us during every respiratory virus season. We get more cases of pneumonia, particularly in older people and with people who have underlying health problems. This year, rather than having that be due to flu, it's going to be due to COVID. And particularly for immunocompromised people, those people who have had transplants or cancer chemotherapy and such, or who are on special drugs for rheumatoid arthritis, it's going to be a riskier time. And we'll talk about in a minute what people can do about that. Will our hospitalizations be as high as last year? A little difficult to predict, but probably not. And the reason why is even though the XBB 1.5 is more immune evasive, there is still enough immunity hanging around from previous infection and from vaccination in the past that it'll help keep people out of trouble with hospitalizations or severe infections 2 to 3 weeks. But we haven't yet really seen hospitalizations surge in those areas. They're going up, but they're going up no faster than, say, down here in the Triad where we still have the older variants. Early data suggests that the XBB 1.5, while being more infectious and a little bit more skittish and evasive, I don't think it's going to be any more serious than our previous variants of COVID. So that's, I think, going to be good news. The other thing is that there's going to be a lot more workplace outages because as more people get COVID and you have to isolate for 5 days with COVID, so that's 5 days out of work. And then we'll go over again, in case people have forgotten, how to get tested and what to do if your tests are positive in a minute. But with more outages, then that means that there'll be less. People will have to work longer shifts, particularly in those areas where there's a lot of public service. So, police, firemen, hospital workers, TV reporters. I'll have to kind of, I think that's going to be the main impact of this. So for the most of us, XBB 1.5, when it comes around down here, is going to be a cold or flu. But for older people and for people with underlying health problems, it could be more serious. It will result in more workplace outages. Let's go over a little bit again and remind ourselves a refresher course and how to get through a COVID wave. We've done this before, and we will do it again. It's not the end of the world. The one thing that's going to be different with this wave than the wave that we had last January, I think you're going to see life a little bit more normal than it had been in the past. I don't see mask mandates coming back, personally I'm not sure they need to come back, but that doesn't mean that masks don't work, because they do. So if you are immunocompromised and need or want to go out, wear a mask, wear an N95. And if you're older, particularly if you're over the age of 70, you're going to want to mask out in public. If you have underlying health problems, you're going to want to wear a mask out in public. And it's okay to do so. There's nothing wrong with that. And you're not going to have to do it forever, because the wave probably will be over probably by the end of February or so. But that's one great way to protect yourself. Wash your hands often. This will help protect you from all sorts of nasty viruses that you could pick up outside. And get a good sleep. Do all those things Mom told us to do to stay healthy. If you have the sniffles, okay, here's what to do, all right. First thing is, if you got stuffy nose, sore throat, you're going to test yourself for COVID. And you can do that at home, or you can go to an urgent care, or you can do it at some of your doctor's offices. I don't think we're going to have the mass testing places open like we did last year. Because of the ubiquity of home tests. If your COVID test is negative, and with your stuffy nose and sore throat, and you have no fever, then you probably have a cold. Retest yourself in 48 hours. Be a good citizen. Stay home from work or school for a couple of days while your symptoms are at their worst. If your retest at 48 hours is negative for COVID, go back to work, but be a good citizen. Wear a mask. The people who are sitting next to you or around you at work, they don't want your cruddy virus, cold virus. So wear a mask when you go back, and that helps. If you're feeling better, that'll help you keep from spreading it. If you have a fever and your COVID test is negative, you probably have the flu, and you can call your doctor or urgent care center and see whether or not getting Tamiflu would be helpful. Tamiflu does take the edge off of the flu. It's not a magic bullet, but does reduce the severity of symptoms a bit and the length of symptoms, but you have to get it treated in the first 48 hours. But particularly if you're older or have health problems, you're going to probably want to get Tamiflu. Unfortunately, Tamiflu's been in a bit of a shortage since last October because of the flu surge across the U.S., but it seems to be letting up some, so I think it's more available now. Now, if your COVID test is positive, well, you drew the red card, and that means you're going to have to take 5 days off of being outside. So you kind of shelter at home, get out that jigsaw puzzle, catch up on Netflix, or work from home, like a lot of us have to do, and spend that 5 days there. If you are older, and here I mean older than 60 or even 55, or have underlying health problems, you want to call your doctor or visit an urgent care and get a script for Paxlovid. And that's the drug that we use for COVID. We've got new data back out of Paxlovid now of how well it really works, and it really helps keep people out of the hospital, including people with underlying health problems and who are older. So it doesn't cure the infection overnight, but it keeps it from getting more severe. So I'm really a strong proponent of getting treated. Now, if you're 22 years old and otherwise healthy, do you really need to have Paxlovid? Probably not. You're going to be at home for 5 days one way or another. Your symptoms will start getting better in 3 to 5 days one way or another. But if you have underlying health problems or are older, you're going to want to get it. There's a new drug that's going to be out in oral form here in a few months. You probably haven't read much about this in the national media. I don't know why it didn't come out. But there was a really good study of using remdesivir in an oral pill form that was done in China last fall. And the study looks pretty good, and was actually published in The Lancet, which is a very good medical journal. And it looks like oral remdesivir works just as well as Paxlovid, but it has one big advantage, is that it doesn't have drug-drug interactions, which makes Paxlovid sometimes a little hard to use in people on certain other medications. And it has a few less of the annoying side effects of Paxlovid. I think that'll have to get. I think that we'll have to see a couple of studies outside of China of that drug, which are ongoing, and then it'll get presented to the FDA. So we'll have another tool in our toolbox that works pretty well. Molnupiravir, which is the other oral drug that we have, that's been kind of third-line treatment for COVID. Unfortunately, the more data we get on it, the lousier it looks. It doesn't really work so well, particularly in the more recent studies. So I'm not a big fan of that one. So Paxlovid's the one to get, and remdesivir orally when that comes out. Unfortunately, monoclonal antibodies don't work anymore for COVID. And these are those infusions you may have heard about, where if you get COVID, your doc gets you set up in an infusion center and you go get a big slug of monoclonal antibodies by vein. They don't work against the new variants. And the other monoclonal, Evusheld, which immunocompromised patients are probably aware of, this is a monoclonal that you get injected once every 6 months or so, and it's to help prevent COVID, but that doesn't really work anymore either. So for immunocompromised patients, they have less options to prevent COVID. They can still use Paxlovid, and they can still get remdesivir IV right now, which is what we've been using in hospitals, or when it comes out orally, you could get it that way. So there are treatment options. So it's a lot better than it has been in the past. A lot more immunity out there, which still extends out and gives us at least partial protection, particularly from more serious infections. If you've been vaccinated or have had COVID before, that's different than it was last January. We have more treatment options. That's different than it was last January. And so I'm pretty optimistic that this wave isn't going to be nearly as disruptive or big as last January's was. And that's kind of the bottom line. A few other things. Let's talk about vaccination. Some good news on the vaccine front. One, our flu shot this year is 100% right on, dead center coverage of the flu virus that's been circulating. And that's really good, because it means the flu shots is very protective this year. And it's not too late to go get it. I mean, there's still some flu circulating. Numbers are coming down, but it's still some out there. So go get a flu shot. The other thing is that if you've never been vaccinated for COVID, now's the time. Go get it, and help get you through January and February. If you have been vaccinated for COVID before but have not received a booster since September 1 of last fall, then go get a booster. And that booster that you will get is the bivalent booster that has increased activity against Omicron and its subvariants. And so the data we have now from the subvariants that were going around last fall is that it's at 70% better than the original COVID vaccine that people would have gotten earlier in the pandemic. and it's at least 50% better in another study for preventing COVID from those variants. How well it works against XBB 1.5 remains to be seen, but we think that it'll have more activity than the original vaccine. So if you haven't got a booster since the first part of September, go get it. Personally, last fall I got my flu shot in this arm and my COVID booster in this arm. And you can do it at the same time. Vaccines are available at the health department. They're available at a lot of primary care places. Then there are still some places, some vaccine campaigns through faith-based organizations and such that are going on. So it's not hard to find these vaccines for either flu or COVID. All of the data show that still that what we know about from COVID vaccines last spring and 2 years ago is really the same as now. They're not causing any more side effects than they did before. Still about 15% of people may get a little achy, a little headachy, maybe a bit of a fever 24 hours after getting the shot. You can take Motrin or Tylenol for that. Very, very rare events with the messenger RNA vaccine include myocarditis. 90% of the people who get myocarditis from that vaccine don't even need to be hospitalized. The absolute rate in young men where it's the highest is somewhere between 50 to 60 cases of myocarditis per 1 million vaccines given. So it's a very, very rare event. COVID vaccine does not cause sudden death. It does not cause heart attacks. It does not cause your heart to stop, unlike some of the misinformation going around on the internet right now, saying that Damar Hamlin's heart stopping on the football field was due to COVID vaccine. I think from those of us who watched that game, watched that guy's helmet go into his chest, and that indeed can make your heart stop. We've known that in medicine for 100 years. In fact, not only if you get hit real hard in the middle of your chest at exactly the right timing between heartbeats, can it stop your heart, but if your heart has been put into an abnormal rhythm and you hit somebody real hard in the chest, it actually can restart it. So it goes both ways. But it has nothing to do with COVID vaccine. That's just bunk. So one last thing, a few things to tidy up. You notice I mentioned that, when you're looking for Tamiflu or Paxlovid or a test, go to an urgent care, call your doctor, check out primary care. Where should you not go? The emergency department, because our AEDs are going to be really busy taking care of people who have underlying medical problems and respiratory infections and such, like we see every January and February. So EDs this is our busiest time of the year. Unless you have a medical emergency, stay out of the ED. And that always is true, actually. The other thing is that we had talked a little while ago about an Ebola outbreak in Uganda. We can all exhale. That outbreak in Uganda is pretty much gone now. I haven't had any cases now for a few weeks, and so I think we're out of the Ebola woods. And there was no exportations to other countries. Uganda did a really good job, actually, with the help of the CDC and the WHO in controlling that outbreak. And we've really made a lot of strides in identification and control of Ebola in Africa in the last 5 to 10 years, and that showed that. The other virus that should be gone but isn't is measles. And you remember last year we had an outbreak in, I think it was Westchester County around New York, of measles in unvaccinated people. 2 years ago there were some pretty big outbreaks in the LA area. Right now there's an outbreak of measles in Ohio. What all these outbreaks have in common is that it's in unvaccinated people who've never had a measles shot or an MMR shot. So most of us will get an MMR shot at age 1 when we're a baby, and then we get another one when we start school at age 4 to 5. But the last few years, the anti-vaccine movement seems to have taken hold, and so fewer people are getting their measles shots. It's still up around 70 or 80% in some of these states. Here in North Carolina, it's above 90% are getting it. But if you don't get your measles shots or your other shots, you are susceptible to all these childhood infections that used to devastate our population. And I can tell you, as a doctor who's seen measles in hospitalized people, saw an 18-year-old die of measles, and I've seen little kids die of whooping cough. Go get, let's get our childhood vaccines when it's time to have that done. And then we won't have these outbreaks anymore. So any questions out there? Talked about a lot of different things this morning. Yes?
Hi, Dr. Old.
Hi.
Yes, from Evidence I have 12 News. I wanted to ask you about emotional health and COVID-19. One of my bosses had told me she had 2 of her friends that actually had a terrible day emotionally, and then the day after, they got COVID. And that was in 2 different instances. Does mental health play a role in receiving the virus at all?
Yeah, so does mental health play a role in, I guess, your susceptibility to catching the virus, which is your question? So we've talked a lot about the other flip side, right? When you get the virus and how that might impact on your mental health, and how the pandemic impacted on mental health in general because of social isolation and people having to change the way their lives. But we haven't talked as much about mental health and your susceptibility to viruses, so that's a really good question. For COVID, I don't know if we know the answer for sure, but I can tell you with other viruses that when you are on the downside or having a bad time in your biorhythms or depressed or having other mental health issues, either mild or severe, that it does increase your susceptibility, because there is a connection between our mental health and our immune systems. So people are more susceptible to getting colds and flus when they're having a harder time otherwise. And so I would say that's probably also true with COVID. It could also be just true and unrelated, because people generally feel more depressed. It doesn't have to be clinically depressed, but enough to want you to seek help. But you have more down days after the holidays. The excitement's are over, you're back at work, and the biorhythms just seem to be kind of like, oh, do I really have to get out of bed today? So that's more common after the holidays. And our respiratory viruses are also more common after the holidays. So they could be nothing more than a coincidence. But there is some connection between mental health and our immunity. So.
And then also, may you please repeat that tidbit that you mentioned about the flu vaccination and the 100% of coverage?
Yeah, in a little bit of how we make the flu vaccine. So it's a little bit of Vegas in this, okay? It's a little bit like going to play blackjack in how we come up with the flu vaccine every year, because it takes 6 to 8 months to make the vaccine. And so we have to predict what strains of flu are going to be circulating in the year of interest. So for instance, for the flu vaccine we made for the 2022 or 22-23 season, this season, we had to decide what strains to put in it last February. And so it's a little bit in predicting the future, right? You don't 100% know for sure. So we look at the southern hemisphere because their season's opposite. And we look at what was circulating the year before and get a bunch of smart people in a room, and then we decide what to put in the flu vaccine. We put 4 strains in each flu shot. So there's 4 different strains. So that's kind of like covering your bet at Vegas, right? It's like using 4 chips instead of just 1. And then, so sometimes, some years, the flu virus shifts and changes some between the time we make the vaccine and the time that the flu circulates. Like for instance, 2 years ago, 3 years ago, the match wasn't very good. This year the virus hasn't changed, so the flu shot works against this virus very well. It's a good match to prevent it. So that's what that means. So
4 strains of the flu.
for strains of the flu, yeah. Any other questions?
You did have a general question about viral shedding. Can you
Yes.
just touch on that?
So viral shedding is when you're sick with the virus, your ability to give it to other people. So for instance, COVID, when you get COVID, most of the viral infection is in the back of the throat and the back of the nose. In more severe cases, it gets down in the lungs. But for most of us, it's up in the nose and throat. And the virus replicates there. So 1 virus becomes 2, 2 become 4, so on and so forth. And you shed it. You shed it in your secretions from your nose. You shed it when you cough. You shed it from your oral secretions. And when you shed it, you wipe your nose. If you don't wash your hands right away, now you got virus on your hands. So if you shake hands with somebody, you can give it to them that way. Or you cough, or just spewing out, breathing heavily, spewing out viral particles into the air around you. And that's how we give it to other people. So if you put a mask on, it helps keep your cruddy virus to yourself, rather than letting it get out there in the world where it can infect other people. And then also getting treated. Getting Paxlovid reduces the amount of virus that is replicating in your nose, so you're less likely to give it to other people. Getting Tamiflu when you have the flu means you're less likely to give it to other people. So it does help, treatment does help prevent transmission as also.
We just got another question. Why do flu tests only check for flu A and B?
Well, our flu test tests for flu A and B because those are the 2 that humans get. So we're not really interested in checking for chicken viruses or chicken flu or bird flu for us. So we do A and B. Most of the flu that humans get is type A. Right now, the subtype of A that we have going around is something called H3N2 of A. And so the tests that we use test for those 2. So we don't need to test for others. There are tests that will test for COVID and flu at the same time. And there are tests that will test for COVID, flu, and RSV at the same time. And those are not home tests. We have no home tests for flu. The only home tests that we have out there are for COVID. If you want to get a test for flu, then you need to get to a healthcare provider. Most urgent cares, most pediatricians have tests for flu and COVID now, so you can get it there. But it's a little bit of just betting as well. Flu almost always causes a fever, headache, and body aches. So if you have a sore throat, cough, and a runny nose with a headache, a fever, and body aches right now, because we have flu circulating, that's probably what you got. You may not even need a test for flu. But if you don't have a fever, headache, and body aches, and your test for COVID is negative, you probably got another virus, a different one. Just remember, as we talked about earlier, to be 100% sure it's not COVID, you should have 2 tests 48 hours apart, if you're using the home test. If you're going to the doctor and they're using an RNA test, 1 test is enough. Maybe that's too much medical talk. All right, I think we'll tentatively plan for the 26th of January to come back. If things get real interesting and busy, we may do one next week on Thursday. So mark your calendars to check. We'll send out a tweet and we'll send out a notice to the media one way or another.